The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes possible scenarios and unknots the threads to find solutions. I'm Dr David Rankin, and this is Safeguarding Healthcare, the Essentials of Clinical Governance. Today, a huge ethical dilemma.
At the end of the day, it raises all sorts of legal issues for the hospitals as well.
That's Dr Paul Douglas, Executive Director, Health Protection with the New South Wales Ministry of Health. And I'm presenting him with a conundrum.
What is the liability for the hospital itself, where someone has a procedure which might be dangerous?
In this Australian-based scenario, there is an emergency call from the operating theatre. A baby has just been delivered by emergency caesarean section and the neonatologist has indicated the baby is unlikely to survive. The obstetrician is upset, as they believe the baby's outcome may have been compromised by a decision not to use the abdominal CTG recorder during the labour and delivery. I started by asking Dr Paul Douglas what issues the situation raises.
First and foremost, I think the most important one to address is the patient and making sure that they and their family have support from wherever that's coming in. There were lots of concerns that I saw here. One is, what is the cultural situation within the midwifery and the obstetric teams? Is there something going on there? The broader patient safety issues in terms of what's the consent processes, what's been provided and communicated to the mother, and how does that then relationship work across the different settings of the different craft groups. It also raises the issue of staff potentially not adhering to hospital policies and how we might address those sorts of facts, and also probably most importantly, where people do deviate from policies that are in place for very good reasons, how that can impact on patient safety. And probably finally is that all these events have traumatic events on the staff who are involved in it, and how that's handled and how we go forward, that I think are things that we need to consider in this scenario.
Let's start with the really thorny question of how much choice do patients have when they want a care option that may not be considered safe. On the one hand, we can wrap them up in cotton wool and make sure everything's done to a very high technical standard, but perhaps ignore them as a person. On the other hand, we could do everything they wanted, but that may jeopardise the health of the mother or the baby. Where do we draw the line?
Wow, David, that's a really complex question. And again, I think becoming much more difficult for people involved in these sorts of levels of administration and governance, because increasingly we are seeing that consumers want to be engaged and involved in the care that's provided to them. In a public health setting, we call that co-design and co-production, and that we shouldn't be actually engaging in any medical procedure where that's not a part and parcel of it. And for a lot of clinicians and medical clinicians particularly, this is a real change for them. Getting back to your question about where does that leave an organisation, how do we try and blend that? I think it comes down to having very clear policies within the hospital about how these things are organised, how the processes are put in place, when does this communication occur, how is it documented, how is it authenticated, and how is it actually transferred between all members of the team so that people are quite clear about what the expectations of the patient themselves are. At the end of the day, it raises all sorts of legal issues for the hospitals as well, which we may be able to talk about later on. But what is the liability for the hospital itself? What is the liability of the individual practitioner, where they agree to support the person in that role, even though they know it may be counterproductive to the safe outcome of either the mother or the baby in this circumstance. And then what does that mean from a professional perspective? What does that mean when we go to the boards and all the rest of it, if there's a behavioural misconduct there? So it's a really wicked problem you've provided here, David, and not one that's easy to do in a quick conversation.
It's a difficult problem. One of the key points that you raise, I think, is a very important one, and that's negotiation. A patient, in this case, the woman, needs to understand what the obstetrician is concerned about. At the same time, the obstetrician needs to understand what the woman's concerned about to try and see if there's a ground to meet. At what point can an obstetrician say, "I'm sorry, I'm not prepared to look after you"?
Again, really difficult question. And it depends on the setting that you're in. And I think back to when I was a procedural GP going back many, many years ago, that you get in these dilemmas where women are very insistent on the birthing plan that they want and the birthing plan they desire. And ideally, the team should be involved in this discussion very early on in the pregnancy and allowing people to fully air what their wants are, what their needs are, and what their desires are. On the obstetrician side of things, they again need to be quite clear about what they're not prepared to do and what they're not prepared to cover. And if it's early enough in the pregnancy, they can say, "I'm not the person for you. Go find another obstetrician or someone else who's willing to care for your baby." Very hard sometimes when you're in a regional setting or remote setting where you may be the only clinician who has to deliver this baby. Or in an emergency situation where there's no other choice and you're the one on call. And I think when you get in that situation where it's an emergency or you're the sole provider and there's no other choice, again, it's part of that negotiation.
So we have a tension between patient autonomy, the rights and responsibilities of the clinician, and their duty to provide emergency care in any circumstances, provided that the care is within their scope of practice.
I think that's probably the answer comes down, David, to the setting and the context. If you're in a big city hospital where there's lots of other people who can provide care, then maybe you should negotiate and find someone else who's prepared to provide that care. If you're in a setting where that's very limited, then you need to be very clear about what you will do and what you can't do. But I think, it's getting back to the whole old adage of what you as a medical practitioner agree to do. You cannot leave someone to do it on their own if there's no other choice. So we always have that duty of care at the end of the day.
We have to make sure the patient has access to appropriate care. Yes.
Yeah.
It's likely to end up in court, and memories will change. The mother's perception of the discussion she had may well be quite different in 6 months' time from what they were leading up to the birth. You briefly mentioned documentation. Tell us about the importance of documentation in cases like this.
It's essential that everyone is on board and records it as much as possible. Triangulating information and documentation is also very important. So not just your own documentation, but the documentation from the midwife, operating theatre staff, whoever else was involved in this sort of discussion needs to be done contemporaneously at the time of the procedure. And in retrospect, not a day later or 2 days later, but as immediate as you possibly can. Again, probably important to wait until your sentiments and your passion has settled down a little bit so that you're doing it in a nice clinical, scientific manner. But I think it is really, really important to document it as comprehensively as you possibly can and of your recollection of the time of what actually happened. I think the other key thing that I would suggest, and depending on the time of day it is immediately contacting legal areas or your insurer and documenting with them what has transpired and what you undertook at that particular time when this has occurred. So the earlier it's done and the more comprehensively it's done with more opinions than just your own is really, really important.
Let's follow that through. The insurers are very likely to be involved in this. Getting staff statements. How do you go about getting staff statements? Does legal take them? Do you take them? Do you delegate it to your registrar? What's the process for collecting staff statements in a high-risk situation?
It's difficult, and again, it depends on the context and the time and where you are and who you've got there to support you. If you're in a major metropolitan hospital, it's a lot easier because you've got a lot of people around there who can support that. And ideally, I would suggest if you're in that situation that you use your patient safety manager or someone who's used to doing this and who's gone out and interviewed people regularly. So there's a consistent process of doing that. I think it's important that you, as the clinician, would not be taking statements, but you could, in my capacity as a DMS, certainly if there was no one else to do that, I would take the statements and I would take it uniformly across each of the individuals there. And I think, again, that consistent approach is probably very, very important. Really important to do this as soon as possible to the event as you possibly can, because people forget things, they change things, or you may not be able to access these people if they go off on leave or are not coping very well with these situations.
Yeah. Incident management, including information gathering such as reviewing the medical records and undertaking interviews, should follow a very prescribed algorithm, which may differ between jurisdictions. Certainly we have a preference, if we can, to bring in our legal team to take statements, particularly if it's likely to be litigated. Lots of people are impacted by this scenario. The midwife may feel she's justified in supporting the patient. The obstetrician, we've already heard, is really angry and they're upset about the outcome. The paediatrician, the other staff in the delivery suite. Tell us how you would go about making sure, I guess, the trauma for these staff members is not multiplied.
Yeah, I think, look, first and foremost, I think the most important one to address is the patient. They're likely to feel angry both at the midwife and the obstetrician for the outcomes that have occurred, and potentially even the paediatrician who hasn't been able to save the baby. So again, trying to make sure that's really structured and well in place. In terms of the staff, each of them will have a slightly different need and be coming from a slightly different perspective. And again, important to bring in their peers or professional leads that they may have and to really just let them talk through those issues, what they're feeling, how they're feeling, and let those key members do it. You may have access to a social worker there who can support that process, or you might have someone who all the team feel quite confident in, who's a clinical leader there, who might immediately leave a hot debrief type situation so that people can just talk about their feelings where those concerns are. Other staff you may need to look at tapping into their professional leads. So for the midwife, for instance, go to the head of nursing midwifery to look at what supports they can put around this particular person. For the obstetrician, again, the head of the department, or yourself as director of medical services, to look at what support you can put in around that as well. Obviously using EAPs and reaching out to those networks, and again, even more formal counselling to go beyond that to support some of their staff who may be critically impacted by this.
Staff debriefing is an integral part of maternity care. It should be set up and ready at any time. It should be multidisciplinary, not separate. It should be led by a trained person, sometimes outsourced. It's very important to separate de-escalation, the immediate response, from debriefing, which occurs later.
No one likes to see a neonatal death, and it can be very, very traumatic. And so making sure that you are there available and providing those supports all the way along this, because it's not going to just be overnight. This is going to be going on for quite some time and supporting staff through this process. Furthermore, I think what this has raised is there's almost certainly an underlying poor culture within the team. And so what you then need to think about in addressing the cultural elements that may be very long-standing. Often I've seen situations where you've got independent midwives working in peripheral hospitals with no obstetricians involved in that care whatsoever. And so that remoteness then makes that even more difficult. And then how do you actually engage the medical teams with the maternity teams or the midwifery teams to try and build that culture is again another challenge and something that needs to be seriously considered. When I've looked at that and been exposed in those situations in the past, I have actually sought more external people, unless you've got a really good clinical leader who can actually bridge that sort of gap and people will have faith in. But I think there's a lot of merit in pulling out someone independent from the people involved to really start to look at what are those cultural elements that do need to be repaired and will take some time to get there.
Yeah, yeah. You've got a staff midwife who may have been trying to provide patient-centred care and autonomy, or may have breached policy and guidelines, doing their job in difficult circumstances. What are your options, and what would determine which way you would go in working with this midwife?
Well, your first option and your only option is go talk to the midwife. You need to find out, did they breach policy? Did they know the policy existed? Did they understand what that policy meant? And did they understand fully the implications? I mean, this might be a new midwife. So I think that understanding of what actually occurred and their awareness of the policies is very, very important. If they were unaware, then you need to look at what's the orientation process and the onboarding processes and how you can ensure that the knowledge of the policies is gained very contemporaneous. But if this person willingly chose to ignore hospital policy, then you need to go down a much more workforce performance track. And for me, myself, I wouldn't be doing that. I'd be engaging with the director of nursing and letting them take that process go forward. If someone willingly disobeyed a policy and we've got a poor outcome, doesn't mean you don't investigate the rest of the process, because there'll be lots of other systems learnings in there.
Yeah. A lot of help from HR.
Yeah, a lot of help from HR.
Particularly for salaried staff.
Yeah.
It is a sentinel event, particularly if the baby dies. What investigation are you going to undertake, and who would be involved in that investigation panel?
Yeah, well, it's pretty much bread and butter, I think, in terms of who you would involve in these particular cases. Also noting it's a coronial inquest if the baby dies as well, so there's all those sorts of things going on. But that, again, would not stop your immediate review of what's been happening with this particular case, and the normal escalation processes and reporting process of who you'll go to it. In terms of the team itself, in this situation, I would not be putting people who are directly involved in this on the team. I think that would be countermand to where you want to go. You want people who are independent, who can look at the process with fresh eyes, and who have the right expertise to be involved in that. So clearly you would need an obstetrician on the team. Ideally, in this sort of setting where it's a sentinel event, I'd be getting an obstetrician outside the actual hospital or outside the health district that they're using. And again, someone who's got the eminence that will be respected in that process. Very much the same with the midwifery staff. You'd need to have that same sort of process, an independent person outside the organisation itself, so that they're working towards that.
All these cases would be ISR 1 and have an RCA type investigation, starting with open disclosure, and in Victoria would follow the SAPSI pathway. Panel makeup doesn't require eminence per se, rather independence, training and systems review, and no conflict of interest.
You probably, I would, in this situation, have a consumer, potentially a consumer from some of the NGOs now who support midwifery-led wives, led births, trying to get a very clear understanding about what that passion might be and how that might contribute to this. In terms of others, I don't know if it needs a really big, huge team, David. And I think the smaller the better if you can in some of these circumstances, as long as they've got the wherewithal and the ability to go to interview people through this process and do that in a very compassionate way going forward. I probably would include my patient safety officer from the hospital to help support and coordinate the activity. And potentially looking at this, you might even think of some of your junior medical staff who might have been involved on the day or included in this, and then how they were negotiating through it, depending on what you're finding out. But I think a smaller team is probably better with the appropriate expertise within those walls.
Thanks, Paul. The obstetrician and/or the midwife involved would not be part of the panel reviewing an adverse outcome due to their conflict of interest. The systems review emphasises the woman's right to autonomy and decision-making, and explores why the collaboration between medical and midwifery staff failed. How can you ensure that the investigation satisfies the obstetrician's need for a safe service?
I think the best way to approach this is working with his peer group, and his peer group is very clearly the College of Obstetrics and Gynecology, and trying to not necessarily convince him that there are other approaches to doing this, but at least allow the evidence to be there. I think the other key thing is that each step along the way, as much as possible, and keeping the review and investigation confidential, is allowing information that can be shared as that process goes on to participants to know what's going on and where things are up to. And that can be the obstetrician, can be the midwife, or it could even be the family.
One of the groups in your hospital, particularly if it's a larger metro hospital, may be the obstetrics craft group. At their mortality and morbidity review meeting, would you try and facilitate or contribute to a discussion on the appropriateness of care in this case? Or would it be too sensitive to discuss at a forum like that?
I can tell you it would be extremely sensitive, and I would be doing a lot of groundwork before I would raise and flag that case, although it will have to be discussed because it's a clear item which would fit on a morbidity and mortality meeting. Me as an independent, and particularly in a large hospital with a large craft group there, I would be working very much through the director of the service, the head of department, potentially the person who coordinates their M&M meetings. Again, broadening this out a little bit to make sure that I would hope that at the M&M meetings they have their midwives. They usually are at most of the M&M meetings for obstetric groups. But again, making sure those views are in there.
All right, this is an Australian-based case, so your insurers are concerned about the risk of litigation. You finished your investigation, delivered a copy of the report to the state body and to your insurers. And your insurers have explicitly said this is a very high-risk case. You cannot share it with the parents. How do you keep the parents involved and informed of the investigation and outcomes when the insurer doesn't want the report released?
Yeah, it's a really interesting question. I mean, it's and probably different in the private settings to the public settings. And so I'm talking more from a public setting perspective here. And I've also practiced, David, the process that whenever there is a sentinel event, that I have personally set up a process where I'm keeping the family informed continuously through this process. So every week I ring the family, and just touch base, even if nothing's changed, if there's nothing further in the investigation, just so that they feel like they've got someone that they can trust and listen to. And I think that's probably first and foremost, because these things take 60 days or 90 days or whatever by the time you get through everything. So if you're touching base with the family weekly, they feel like they've at least got an ally there. I think the other key thing is you still need to let the family know some of the aspects that have gone in there. And you can do that in a way which doesn't necessarily release the physical report, but you can talk to aspects of that report. And again, if they trust you and you've been with them along this ride the whole way, most of the time they will grudgingly accept that position, even though they will go off and take their own legal action and try and get a copy and all the rest of it. But again, I think it's just maintaining that communication right throughout, but noting this is a very contentious legal situation, which is potentially going to have large amounts of dollars attached to it. So you've also got to listen to your insurer, who's got a role in this as well.
Yeah. Come back to the culture, just to finish up. How are you going to facilitate a culture that avoids no blame? The obstetrician's clearly ropeable with the midwife. The midwife's ropeable with the obstetrician. And there's this toxic culture of they should be fired or they shouldn't work here. How do you heal the rifts in a toxic culture?
First and foremost, as we said right at the beginning of this conversation, is that both staff members need to feel that they are supported in this. So they do need peers and they do need people that they feel that they can talk to and provide that support as they go through. You won't solve this in 3 months. This is going to take, I would say, many, many years to probably rectify completely, but you need to get a safe environment and where people can agree with some rules that they can abide by and how they will escalate issues where they feel that we're getting into difficulty again so that someone can be called in very quickly to mediate in those circumstances.
Yeah, moving beyond the personalities to the patient.
Exactly.
Thank you very much, Paul.
No, it's a pleasure. Thanks for the wicked problem, David. I repeat, it's such a prominent issue and going to be more and more demanding.
And that brings us to the end of this episode of Safeguarding Healthcare, where I discussed an avoidable death of an infant with Dr Paul Douglas, Executive Director, Health Protection with the New South Wales Ministry of Health. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.